March 23, there is a total of 86,200 active cases.
So good evening, everyone, and welcome to this webinar, which I'm happy that was organized in partnership with the Department of Health, USAID, the EPIC project, and of course, the Philippine College of Chest Physicians. So definitely, this is a collaboration of sorts. And definitely, I would like to welcome the participants. We were scrolling down the participants. They are pulmonologists and internists from all over the country. So from really far off in Cagayan up to the southern part of Mindanao, we are ably represented. And I think because the main topic right now is indeed timely, what with all the surges that we're experiencing, again, as they say, it seems to be deja vu. We have been at this for about a year already. It seems like, yes, there are success stories, but definitely there's room to grow. And so I would like to welcome everyone to this collaborative academic exercise, COVID-19 strategies and management, hits and misses. So definitely we will be highlighting certain things that have been experienced by a frontliner from the US to be able to learn certain lessons, and hopefully we can, perpetuate the success stories, and based on the lessons learned, maybe we can improve it considering our setting. So definitely I would like now to have a virtual welcome remarks from our distinguished panelists. So from the Department of Health, I would like to welcome a Medical Officer 5 from the Office of the Chief of Staff. From the Department of Health, let's all welcome Dr. Anthony Koo. Dr. Koo?
Good evening. So, to USA Director Michelle Lang Ali, FHI Country Representative Dr. Soliman Gurgis, PCP President Dr. Gregorio Ocampo, Dr. Hubert Benedicto, Prof. Lundi Campbell, friends and colleagues in the health sector, ladies and gentlemen, on behalf of Undersecretary Leopoldo Vega, let me greet everyone. Maayong gabi, good evening. I know that everyone here today is aware that COVID-19 cases are again increasing in our country. As of March 23, there is a total of 86,200 active COVID-19 cases. While it's true that most, or 95.4% of these are mild cases, and only 0.9% are severe, and another 0.9% are critical cases, the absolute number of these small percentages is still problematic, as these translate to 805 severe and 760 critical cases. To compound the problem, many of our fellow healthcare workers in the last few weeks had gotten infected themselves. The increase in COVID-19 cases has gotten very alarming, surpassing even last year's peak. NCR, Region 2, 3, 4A, 4B, 5, and BARM showed consistent positive growth in cases during the recent 6 weeks period, which translate to higher risk of healthcare utilization rate and potential high critical risk ICU utilization. 1 year have passed, but this pandemic continues to provide challenges and hurdles in the health sector. It is very timely to have this webinar on COVID-19 strategies and management hit and misses. Through the joint efforts of the FHI, USAID, and the Philippine College of Chest Physicians, let's continue working together prudently and aggressively, using innovative and evidence-based intervention to provide immediate healthcare services to our patient and the community. It may be exhausting, but we shall carry on in upholding our efforts to once and for all end this pandemic. In behalf of Yusek Vega, who unfortunately is attending other matters with regards to COVID-19 response, our sincerest gratitude to all the participants. To our partners, FHI 360, USAID, Philippine College of Chest Physicians, who have been continuously working together to establish a strong community of practitioners that will provide appropriate COVID-19 critical management by sharing recent updates, best practices, and challenges to physicians involved in critical care for patients. Let us work hand in hand to continue to expand our camaraderie and collaboration in providing quality health services to our patients. Together, we can beat COVID-19. Together, we can achieve greater heights as noble frontliners of health service delivery to Filipinos. Daghang salamat. Good evening to everyone.
Thank you very much, Dr. Ku, for ably representing the office of USEC Bega. Indeed, definitely, we are anticipating that your office will be at the front line together with all the frontliners right now who are actively listening. And so one of our partners, I would like to call to the virtual floor to give her welcome remarks. Ms. Michelle Lang Ali, who's the Director of the Office of Health, USAID Philippines. Ma'am Michelle.
Thank you. So first I'd like to acknowledge Dr. Anthony Ku, representing the Department of Health, Office of the Chief of Staff, headed by Undersecretary Leopoldo Vega, Dr. Gregorio Ocampo, President of the Philippine College of Chest Physicians, the PCCP Board of Directors, healthcare providers from the public and private sector. Magandang gabi po sa inyong lahat. It's my pleasure to join all of you today. I represent the United States Agency for International Development, or USAID. USAID is the lead U.S. government agency for development and humanitarian efforts to save lives, reduce global poverty, strengthen democratic governance, and promote a path to partner countries' resilience and self-reliance. We welcome the participation of our doctors in both the public and private sector in this webinar on COVID-19 case management. Thank you for joining us in spite of your very busy schedules. We also thank the Department of Health for its leadership in the country's COVID-19 response. And we recognize the pivotal role of the specialty societies, especially the Philippine College of Chest Physicians, in improving the management of critically ill patients. I commend you all for all you are doing to provide the best possible care under very, very challenging circumstances. We also need to thank the Meeting Targets and Maintaining Epidemic Control, or EPIC, project team, headed by Dr. Solomon Gurgis, for sharing their expertise to boost local knowledge on COVID-19 management and to help doctors, respiratory care staff, and nurses gain access to the latest information on COVID-19 clinical care. The EPIC team is also learning from the medical frontliners how they manage COVID-19 cases and the different services they are able to provide, while at the same time protecting themselves from the virus. As Dr. Ku said earlier, during the early part of the pandemic, as much as 20% or 1 in 5 reported cases were health workers. It is in our best interests to understand how COVID spreads and how to manage those who get sick in order to cut transmission. Timely and successful treatment of COVID cases will not only save the life of the patient, but also protect the patient's family and community from getting and spreading the virus. You are a critical link in the chain of interventions needed to halt the spread of the virus and in ending the pandemic. Since the declaration of this global emergency, USAID has worked closely with the Department of Health and other partners in the areas of critical care management, infection prevention and control, laboratory strengthening for COVID diagnosis, risk communication, procurement and supply chain, community response, and WASH-related assistance. We have also provided 100 state-of-the-art mechanical ventilators to 46 COVID referral hospitals, and USAID has trained over 350 ICU workers on planning and forecasting of critical care supply needs and critical management. To date, the US government has invested more than 1.1 billion pesos to support the Philippine COVID response efforts. The US government, through USAID, has also provided an additional $2 billion or 97 billion pesos contribution out of a total planned $4 billion or 194 billion to support the purchase and delivery of COVID-19 vaccines for 92 countries, including the Philippines, through the Gavi COVAX Advanced Market Commitment. In fact, at least 20% of the vaccines the Philippines will receive through COVAX are funded partially by the United States. With the upsurge of cases reported recently and the DOH announcement about the presence of new variants in the country, we need even stronger and more coordinated action to ensure the health and safety of Filipinos. As a close friend, partner, and ally, USAID remains committed to supporting the government of the Philippines in this global fight to end the pandemic. Maraming salamat po.
Thank you so much, Michelle, for those welcome remarks. Indeed, cooperation will go a long way, especially in grappling with this pandemic. So now I would like to call to our virtual floor the country representative of FHI 360 Philippines, Dr. Soliman Girgis. Dr. Soliman?
Yes, thank you, Dr. Joubert. Good evening, everyone. At the beginning, I would like to acknowledge and thank Undersecretary Dr. Vega for his continuous support and collaboration and encouragement. And also Dr. Anthony Koo of the Department of Health Office of the Chief of Staff, who is representing Dr. Vega and be with us today. Also, I'd like to extend my sincere thanks to Dr. Gregorio Ocampo, President of the Philippine College of Chest Physicians, the BCCP, and the BCCP Board of Directors, and to Ms. Michelle Lang Ali, the Director of USAID Office of Health in the Philippines, for being with us today in the opening of this webinar, COVID-19 Strategies and Management Hits and Misses. This town hall webinar is co-hosted by the BCCP and organized by the USAID's Meeting Targets and Maintaining Epidemic Control, or EPIC in short, project, in collaboration with University of California, San Francisco, which is represented today by Dr. Landy Campbell as our speaker. And thanks, Dr. Landy, for being with us today, despite it's very early, I'm sure, on your side. I would like to start by sharing a statement we received from one of the medical frontliners who is working in Luis Ora Regional Hospital. He's one of more than 500 critical care providers that EPIC project trained on critical care management. He said, and I quote, "These ventilators transformed our pandemic response. We are seeing patients who need respiratory support actually being hooked to these life-saving ventilators that has been provided by USAID. The USAID EPIC project mandate is to provide technical support in the areas of critical care management for persons affected with the COVID-19. This technical assistance provided was informed, shaped, and designed by the outcomes of an extensive facility level assessments conducted by the project at the beginning of the project last year. Among different TA activities conducted, there is more than 500 critical care providers were trained on Learn COVID, which is a comprehensive learner-centered interactive training package, which engaged participants in learning process and addressed their questions and clarification through an open discussion platform. This training package will be developed within the coming few months developed in an e-format and will be uploaded to the DOH Academy to be available and accessible to healthcare providers working in this field beyond the life of the project. 2, a mentor-mentee program designed through identifying certain facilities as a center of excellence, mentor, and link them to facilities that need support and guidance through establishing a process, a mechanism, and on how these mentor hospitals and facilities provide on continuous support and mentoring to the other facilities that need such support. This is unique to the EPIC project in the Philippines, and actually now other projects in other countries, they are adopting the same methodology and the same process. 3, develop and train on several tools for ventilators, consumables projection and quantification to assist the facilities in keeping the ventilators functioning without any interruption. This event, which comes as part of establishing a community of practice mandate of the project, through which we are sharing the most updated information and technologies in this field. At the end, I would like to extend my sincere thanks to Dr. Juber Benedicto, the team lead of the wonderful local technical team of the project, and the Family Health International 360 team supporting this project. And special thanks to Dr. Landy Campbell for his significant contributions and support to the project in the Philippines since its start. Thank you all, and I wish you a very fruitful event. Good evening, everyone. Over.
Thank you very much, Dr. Soliman, for this welcome remarks. Indeed, there are inspiring stories that can be shared at the forefront. And now, may I call on the President of the Philippine College of Chest Physicians, Dr. Gregorio Ocampo.
Thank you, Dr. Joubert. Good evening, friends and colleagues and our partners from USAID, Ma'am Michelle Lang Ali, from FH1360 Philippines, Dr. Suleiman Gurgis, and from the Department of Health, Dr. Anthony Koo. It is my pleasure to welcome you all to this evening's conference entitled COVID-19 Strategies and Management, Hit and Misses. We have experienced a surge in our COVID-19 the last few days that has almost crippled us the past year. The Philippine College of Chest Physicians is committed to provide continuing medical education with regards to this pandemic. Understanding the importance of the effect of this disease in our country and knowing the important lessons from other countries' response are worth sharing. I believe that our participation in this webinar means we are in the right time and right place today with our distinguished speaker for tonight. Let us then accelerate the exchange of ideas and scale up the best practices and lessons learned in the COVID-19 management. I am confident that everyone will find new ideas, fresh energy, and novel partnerships to sustain all our efforts in the management of COVID-19, especially in the critically ill patients. I wish you all a very successful conference. Thank you, and please stay safe.
Thank you very much, Dr. Ocampo. Thank you for those warm opening remarks from the Philippine College of Chest Physicians. And indeed, this will be conducted in a town hall type or style of conference. So that means we're not going to use some slides. We're just going to have an outright interview, a candid interview at that. And hopefully there will be more time, for question and answers. We'll try to address each and every concern. And of course, let's take advantage of the man who woke up very early in the morning, an intensivist who's at the forefront of all this fight for COVID. He's a professor of anesthesia and critical care from the University of California in San Francisco, a true frontliner, here to share with us his experiences as far as managing COVID, especially those who were categorized as severe to critically ill. So may I call on Dr. Landy Campbell. Good morning to you, Dr. Campbell.
Good morning.
Hi, Dr. Landy. Good morning. So what time is it right now in your area?
It's almost 4 a.m.
Oh, okay. So we're going to give you strong coffee afterwards. Definitely, you're going to have strong coffee from the Philippines, the Barako coffee from our president, Dr. Ocampo. So definitely, it's a good time for us, considering we are in the thick of the surge, to possibly learn some important lessons from you. So let's set the scene first, Dr. Campbell. Can you give us a brief picture of what is your center? Where is it located? What kind of patients do you see during this pandemic?
Yes, so good morning, and I will apologize for any misspoken things I say because it's a little early. And good evening for everybody. Yes, so I am a critical care physician at the University of California in San Francisco, which is a large, what we would call a quaternary care facility. So it's one of the largest facilities, health facilities in California, one of the largest in the United States. And we deal with all different types of COVID patients. And that has been, you know, we've seen this COVID epidemic for the United States has been particularly bad. And we have seen a relatively large surge. We've been spared a little bit here in California, especially up in the San Francisco Bay Area compared to Los Angeles. But we have had quite a few number of patients. We're on our downturn now of our COVID surge, although I'm not 100% sure that will continue given how Americans seem to act around COVID, which I could talk a little bit more about. And I did see, and I can talk a little bit too, when the pandemic first hit the United States, New York City was the kind of the epicenter for COVID within the US. And that was, and I traveled there at the peak of that epidemic for a month to work there during their COVID experience. But yes, my hospital, we have everything, you know, available to us, including extracorporeal membrane oxygenation, or ECMO, for patients who are seriously ill on COVID. And we try to ration that as much as possible because we only have a few of those circuits that we are available.
Yeah,
but,
so Dr. Campbell, how many patients do you usually see during those times on a daily basis?
So we have different, so in the ICU at our peak, we've had as high as in California in our peak, we've had approximately up to about 30 ICU patients with COVID in the ICU only. Within the hospital, much more. When I was in New York, in that hospital, which was in New York City, that was a 500-bed hospital. They had over 700 patients in the hospital, all COVID, every one of them. And at that point, we had well over 200 patients in the intensive care unit, which they didn't have capacity for. So they built out everything that they could, including the cafeteria became an ICU. So that was truly the other extreme of what I've seen for COVID, when all resources essentially get overstretched and start to fall apart. But for us here in California, it's been better.
Yeah, so how did you respond during those initial stages? I mean, did you, let's say, ask help from other states just to go to New York? How about the equipment? Were you able to pull out, these machines? Because I'm just guessing, of course, other centers would have, of course, needed them as well. So how did you prioritize these patients?
Yes. So what happened with New York was it was a rough time because nobody knew exactly what was going to happen throughout the US. So New York got hit hardest right away, and there were quite a few of us that wanted to volunteer to travel to New York City to help out, which they desperately needed. Our hospital was initially a little bit hesitant to do that because they didn't know if we would have enough personnel to be able to stay at home, to be able to fight a large outbreak here. Thankfully, that didn't happen. And so we were able to send a fair amount of people out to New York City. And the problem there was really, there was lack of personnel. I mean, there's lack of everything. There was lack of personnel, especially highly trained personnel. So respiratory therapists, nurses that had critical care experience, those people were in incredibly short supply. We ran out of most everything. We had plenty of ventilators. So that was the first thing, that there was a big stockpile of ventilators that people donated to for New York City. And that was the first time that I really realized that, you know, you can have all these ventilators, but if you don't have the personnel and the training of personnel to be able to run these, they're mostly useless. And what was interesting, and you know, I had experience with the Vyaire ventilator, the same ones that we've sent to the Philippines, and I love that ventilator. And that was by far the #1 ventilator we had in New York City as our workhorse. And it is a fantastic ventilator. It really is. It works and works. So, but we didn't have enough dialysis machines. We didn't have enough physical space. Medications, we ran out of most everything at certain times. We were even using transdermal.
So very interesting. So I think that's the first important lesson. It's not enough that you give, let's say, machines, or you designate a space. Let's say, let's turn this ward into an ICU. But definitely, you know, if you are still short of adequately trained, qualified manpower, then it's going to be useless, even if you're going to have that space, even if you're going to have those machines. So my first question for you, Dr. Landy, is let's say, what clinical pathway did you follow? Do you have some sort of, let's say, some clinical pathway from your center or from the US, so that, you know, in a certain way, there will be standard that can be followed, standard way of approaching patients who were categorized as severe to critical?
Great question. And yes, so I think the first thing to remember in this is get back to the basics. And it really comes down to good critical care management of patients with acute respiratory distress syndrome. And that is the #1 thing. And so at that point, there wasn't a lot of therapeutics that were available to us. We were starting, Remdezavir was coming out, and we were using some of those things. But by and large, it really came down to, you know, using low tidal volume ventilation, trying to minimize the amount of oxygen you were giving to these patients if possible, and just good quality kind of, you know, critical care management that we do for somebody who comes in with a trauma or a burn or something like that, the same kind of thing. I think the big difference that we started at that point, because we were looking at what was going on in China at the time and what their experiences were. So there was a greater use of proning than had been prior used in the United States at that point. I mean, that's, you know, in my career, and I'm sure you know, going back, there's been a debate about whether proning has been good or bad, and people have, you know, that there's been a lot of literature on that, and that was a little challenging because most people were not used to proning patients and how to prone patients, and so there were definitely some misses on that as far as you know, it was a steep learning curve for people to figure out how to do that well. But otherwise, you know, just having good practices of keeping patients' airways clean with, you know, suctioning. There was some challenges with what kind of, before patients would come to needing a mechanical ventilator, how we would ramp up their oxygen therapy, whether or not we would be able to put them on high flow nasal cannula, something like that. That was not used at that hospital for fear of aerosolizing COVID. The
Same here.
PPE wasn't as great at that point. So, and I think that was a challenge for a lot of patients. And there just, as I said, there wasn't enough people to good quality nursing care to keep track of these patients as well. So that was a real problem.
Okay, so maybe we can touch a little bit as far as, medical interventions are concerned. I think you have highlighted, and maybe it's the same in the Philippines, the way we approach patients who were hypoxemic. Initially, it's outright intubation, but we learned that because it might cause more injury than benefit, we now conserve them. And then, as what you mentioned, we resorted to high-flow nasal cannula. And I agree with you, it's a steep learning curve, especially for the concern of the healthcare worker. Is it safe? Is it aerosol generating? Will I be safe doing it? How about if you're going to prone? Will that require more manpower hours, etc.? But maybe at this point, considering what we have learned, through the months of this pandemic, maybe two questions at this point. When do you use Remdesivir as of now? And when do you use Tusciluzumab or its, same category as Tusciluzumab, such drugs as Tusciluzumab, which is available in the country?
Yes. Okay. So let me talk about Remdesivir. So we are using Remdesivir throughout this entire pandemic. I think the data shows that early use of Remdesivir definitely, in the New England Journal of Medicine article, it shows that the earlier you can get on Remdesivir before patients are intubated tends to have the best outcomes. We try to, when we have patients that come in, we try to get them on Remdesivir as early as possible if they're heading towards more severe disease. When the pandemic first hit, Remdesivir was in extremely short supply. We had very little quantities of it. And so we're having at that point to give it to more the sicker patients. That has been shown not to help as much in that patient population. And thankfully those supplies have increased. What we see at the University of California is we get a lot of patients that come in from other hospitals that are referred to us. As they get a patient that comes in, they basically, these patients, like any big tertiary or referral hospital, they get that local hospitals take care of patients as much as they can and then refer them to us. Most of those local hospitals are using Remdesivir early with good data. And so a lot of the patients that we get now have already had their course of Remdesivir. Tusciluzumab, when I was in New York City, that was first also coming out as well. And they were in the study to look at how that was being used. We clearly, at this point, we are not using Tusciluzumab in the United States as much, or at least at the University of California. The evidence for it has been relatively weak. Again, I think it just needs to be given earlier than later, and that's been part of the issue. We are also using baricitinib, and that we see, again, that seems to, I think the evidence for that is a little equivocal as far as whether or not how well it works. But again, if it's given early, along with Remdesivir, that seems to be the best therapy. That's not one you should wait until you are already on the ventilator. That should be given ahead of time before you place these patients on mechanical ventilation.
Yeah.
Yes, sorry.
Yeah. So there are some questions that keeps coming right now. So basically the main query is that how do you adjust? When we started, it was hydroxychloroquine, and then subsequently, because of the studies, we have to abandon it. It was not the magic pill. And then subsequently Remdesivir, and then Tusciluzumab, the use of high flow. So sometimes you will, studies will tell us this should be used concurrently concurrently or simultaneously for the best outcome. As what you have mentioned, studies consistently will tell us we should use them early. So one question by a participant is that how do you adjust in terms of your standards of care? Because, you know, it keeps evolving. So on one hand, we would like to follow a certain pragmatic way of approaching these patients. That means less variation if possible. Yet, you know, as evidence keeps evolving, sometimes you have some personal views as a physician that may, you know, go against what is being said by the studies. So how do you keep abreast? Do you follow certain guidelines for your hospital that whatever happens, we're going to follow this guideline?
Yes, that's a excellent question and comment. I think that's been a real challenge for everyone, I think, and certainly in our hospital as well, because people do have strong opinions about that in their own experience, they feel like this has worked well for them. What we do is we have a basically combined with our infectious disease department and our critical care department, we keep abreast of the newest data and studies that have come out on COVID therapeutics and just COVID management. And then that is put out and we try to keep a basically a running list of how we should have how we should currently manage patients with COVID. So every week there's essentially like a webinar that comes out that has the latest as far as what COVID management should be for these patients. So you can go to that, it's recorded, you can look at it at any time because frequently it's not at a convenient time for a lot of clinicians, but they can look back and it's recorded. And then there's also a list that comes out as this is what the current management should be for these patients. I can't hear you, Dr. Joubert. Oh, sorry. Sorry.
Yeah, for
I missed
Remdesivir. Yes.
Sorry, I missed your last. It was I couldn't hear that.
Yeah, for Remdesivir, do you use it immediately once your patient will require high flow nasal cannula, or let's say even if the patient will just require low flow oxygen support?
So now excellent question. So now that Remdesivir has become more widely used, what we're seeing, and I'll speak a little bit more to some of the local hospitals around me rather than just what at UCSF, because those are the patients that they're usually seen at the local hospitals first before they are transferred to us. And usually patients are placed on Remdesivir once they see their oxygen needs starting to escalate. So if they're comfortable on low flow, 10 liters or less of nasal cannula, then they usually, unless they see their trajectory heading towards worsening disease, they'll usually reserve it and not give it. But once these patients are looking like they're starting to become more active in the sense of getting worse, then they'll place them on Remdesivir early, and which I think is the best evidence that these patients, they try to get it before they're on a lot of oxygen, because sometimes, as you know, these patients go from looking relatively good on not that much oxygen to suddenly being, extremely sick, high flow nasal cannula oxygen, all the way to intubation within 24 hours. So the earlier we can get that Remdesivir on board, probably the better it does work.
Yeah, so other questions that keeps coming. So for severe and critically ill patients, you believe it's for dexamethasone, the highest that you go is just 6 milligrams, because I think some of the doctors here are giving 10 milligrams of dexamethasone rather than 6. So what's your opinion as far as the optimal dose of dexamethasone? And then before I let go of this question, there's another question. Your opinion first, please, Dr. Campbell, on the use of ivermectin for COVID. So two questions.
Okay. So let me talk about ivermectin. I think ivermectin, there's no data to support its use. It would be wonderful. I think, in my own opinion, it's going to be another hydroxychloroquine. It's one of these medications that seems somewhat promising in very small trials that are not really randomized controlled clinical trials, but are just, somebody has they've given it in these small series of patients, and they're uncontrolled studies that show that maybe it is a benefit. I think that there is, my own opinion, it's weak evidence for it at best. We are not using it. I think these things have an unintended consequence too, because we do need ivermectin and we do need hydroxychloroquine for their intended use. And if they're not really of benefit to patients, and sometimes they can be of harm, like hydroxychloroquine was shown to be, then there's also an unintended harm of not having these medications available for other patients who need them for the real intended purposes of that. Regarding dexamethasone, we stick to low dose dexamethasone. I've seen anywhere between 6 to 10 milligrams, usually 6 milligrams, I think, is the best dose. Steroids are, I can talk a little bit about steroids. As you know, I think, steroids, one of my mentors, Dr. Maffei, who basically has done a lot of work with acute respiratory distress syndrome, has this study saying that basically, studies come and go, but steroids never die. We want steroids to work. I think this is the first time where we've actually really seen that steroids can actually have a real benefit, because there's such a huge inflammatory response to COVID, unlike other acute respiratory distress syndromes. So it's interesting, but steroids are kind of like a double edge, right? They have in this case they work, but if you knock the immune system down too much, then you have all these other opportunistic infections and everything else that can come along. And so I think we have to be careful and stick with what the real study guidelines are on the use of steroids and dexamethasone.
So for the use of steroids, other questions here. Let's say if the patient can be discharged, do you switch to methylprednisolone from dexamethasone? And if yes, how long do you give it? Since based on the study, it's around just 10 days. Do you give it more than 10 days, the steroids?
Yeah, great question. So in my practice, I would still stick with 10 days because I think that there's no reason to extend that. And yes, I know that there are people that have switched to methylprednisolone for that. Probably reasonably fine to do that. I think, the study looked at dexamethasone. I don't think there's anything magic about dexamethasone versus other steroids. But I think prolonging the steroid use beyond 10 days, there's no evidence to show that that would be a benefit, and potentially could cause harm on patients if it goes out for too long. So I would still stick with the short course, 10-day course, even on a patient who we discharge.
Okay, got you. How about, so other questions here. How about, since we are managing patients who are severe to critical, we do give them, let's say, low molecular weight heparin or some sort of thromboprophylaxis. For those who have no proven, let's say, thrombosis or embolus, when they get discharged, do you still maintain them on low molecular weight heparin or other thromboprophylaxis agent?
We have not been, if they don't show that if they have ongoing, if their D-dimers are very high, if they have evidence of, ongoing kind of high inflammation, kind of thrombotic potential, then we do tend to keep them on it for a little bit longer. But otherwise, I think there's no good data to show that you need to keep these patients on it outside the hospital once they have, if there's no evidence that they are, they're recovering, there's no evidence of ongoing thrombosis. I think it's safest probably to take them back off that medication.
Yeah, so you have been mentioning that, of course, in keeping with the guidelines for severe and critically ill, these patients will be given oxygenation once they get intubated. Then the possibility of, of course, all these patients will get some protective lung ventilation strategies, and if they need to be prone, they will be prone. How about the use of neuromuscular blocking agents and sedation? Any concoction? Any favorite concoction?
Yes. We tend to use neuromuscular blocking agents very routinely for these patients that are critically ill. I think that, you know, when I was first training, there was some big worry that, you know, prolonged use of these neuromuscular blocking agents would lead to a lot of weakness and everything post care. But these patients tend to, what we've seen mostly since some studies, especially this French study that came out years ago, it's safe to use neuromuscular blocking agents. And so we generally use I think we use cisatracurium because that is more available in the United States. I know worldwide atracurium may be more available depending upon where you are. I mostly because I want something that will just kind of disappear and doesn't require on any sort of renal or hepatic clearance, because some of these patients, fair amount of them do go on to multi-organ failure. And so I think that's a very safe drug to use. So we've been using it pretty aggressively. You asked me about something else.
Sedation.
Other sedation, yes.
Any favorite concoction in terms of sedative agents? How do you titrate them up? What do you combine?
So I think, you know, when let's maybe break this down into like the really severe patient who I expect to be on the ventilator for a long period of time. So we get those patients who especially are referred from an outside, you know, local hospital because they put them on the ventilator and they see that the trajectory of this patient will be that they may be on the ventilator for a prolonged period. And we've had patients that have been on the ventilator for over a month easily. So in that patient population, you know, then normally we have avoided use of things like, you know, high dose narcotics or benzodiazepines such as, you know, Ativan or midazolam or those drugs. But for this population, we've been using that more often because of the negative effects that we see when we have a patient who's on something like propofol or those drugs. I think those are great because you can titrate them on and off very quickly. We do have a problem with those patients having high triglycerides and then having to come back off them. So we tend to use a fair amount of narcotics and benzodiazepines relatively early in these patients. They do get switched over to stuff that's a little more long-acting, stuff like methadone, because it's very effective, it's available. And then we, you know, if you will, we deal with the kind of weaning back off of that stuff later if that patient still survives. So it's a bit of a challenge. Usually at some point we will wean them back down. I think that we still tend to use a fair amount of dexmedetomidine or Precedex for these patients, an alpha-2 agent. I like that drug. It's a great drug for sedation, but usually not strong enough for somebody who has a really hard drive to breathe, and we have them on low tidal volume ventilation. Need something stronger.
Since we are on that particular topic, what the participants are getting is that, of course, these patients will be given proper oxygen supplementation from low flow to high flow, possible intubation, protective lung ventilation strategy, proning if possible. They will get some sort of steroid, preferably dexamethasone, remdesivir, and other agents like tocilizumab. There are positive signals in terms of using them. Are there any more, you know, drugs that are part of your cocktail in terms of once you encounter a severe to critical patient, you know, it should be automatically part of that cocktail, aside from the sedation and possible neuromuscular blocking agents?
Right. So we have, did you mention convalescent plasma? That's been,
Not yet.
Yes. Okay. So we are using convalescent plasma still pretty routinely. There's mixed data on that, and I think that people still tend to feel like the benefit may outweigh, even if it has some benefit, there's probably low risk to it. So we are using it. And we still have a good supply of it, so that we can usually get it on patients pretty early. And again, I think that's a reasonable option. There is some, if you go to, I do want to mention, as far as therapeutics while I'm here, and I'm not trying to put a plug in for this, but for opencriticalcare.org, which is something that we have worked on through the University of California, there is right up front, there is a web page that has all the therapeutics for COVID that have both we kind of put them into three categories of, excellent data for marginal, kind of not sure if this is good, and then weak, very probably shouldn't do kind of stuff. So Remdezavir would be in the yes, you should do it, and hydroxychloroquine would be no, you shouldn't, and then there's all this other stuff that's in the middle. Convalescent plasma now is kind of moved into the middle category, but it's based on a lot of other, so there's links to, there's links to the data behind it, and then there's also what other centers are doing. So that's a good place. If people have the ability to go to that, I would recommend going to that
Yeah,
website.
so for the participants, opencriticalcare.org, you can visit it. It's a good, it's a good site that for you to navigate, and there are a lot of information there, and it keeps you updated as far as the virus intervention. Going back to the convalescent plasma, Dr. Landy, do you have any criteria? Do you give it early in the course? Let's say if you were able to catch the patient within, let's say, 7 to 10 days of his symptoms, or are you going by biomarkers in terms of when to give convalescent plasma?
So generally, we've been giving it when the patient becomes more critically ill. So at the point, the data probably supports giving it as, that again, all the data on this stuff shows that early use of these therapeutics tend to be the best. But given that the way that these patients arrive, and that they are coming from local hospitals to us, it's a bit of a variant. We get a bit of a variable whether they've had convalescent plasma or not. Most of the local hospitals around us are giving convalescent plasma early in patients, which I think probably has the best potential. Once the patient is in really bad ARDS from COVID, it's really more the inflammatory response that's going on. And then I think a lot of these therapeutics don't have the power to really turn that around. Steroids may be the best help in that point, but other things probably not so much. So giving that early is a benefit. And we tend to, if a patient comes in bad ARDS and they haven't received convalescent plasma, we will still give it at that point, because just with the hope that they will actually, improve.
Yeah. So how about, let's say, what's your experience as far as, since you took care of these critically ill patients, when they get discharged, there's still some fibrosis there. So any experience on, let's say, giving your anti-fibrotic agents for these patients, who gets discharged, they are already recovering from COVID or recovered from COVID, yet they have some form of dyspnea. You do CT scan on them. You are given this CT images of fibrosis. Will you go on and give, anti-fibrotic agents? How about, let's say, there's one question here, the use of steroids for possibly late organizing pneumonia?
That's a great question. And that, so yes, I think that we're kind of entering a data-free zone when we're looking at that. So is what I would call that, where we don't know if we don't know the long natural history of these patients that have the fibrotic stage post ARDS is. All I can really extrapolate from would be from other ARDS where we have patients in the post fibrotic stage, and that that in that case, usually steroids have not been shown to be helpful. However, the disease is different, and so it's hard to know if the post-fibrotic stage for COVID is anything different than it is from if I have ARDS from, say, community-acquired pneumonia of whatever. So I think it's not unreasonable to try it, but I can't stand on firm ground and say that these drugs will be helpful in this patient population, because my understanding of this disease at this point is we simply don't know what the long-term effects of these people that are coming with post, severe ARDS from COVID. Just like we don't know what happens. There's this population of people that get, kind of almost more of a mild to moderate, not severe disease, but they end up with this long-term kind of, post-COVID kind of respiratory illness where they don't seem to be able to have, an exercise tolerance and all that. We just don't understand what the long-term effects of this drug.
We need more data for the long haulers.
Yes.
So just to answer some questions here, yes, Dr. Lande already answered that for Remdezavir and baricitinib, they frequently will give it, especially if they are anticipating that the patients will be let's say requiring more O2 support. So that's the sweet spot when to give it. Before we leave the topic on convalescent plasma, do you qualify that it should be high titer convalescent plasma? What's your practice in your institution?
Yes, we try to get very high titer convalescent plasma.
All right.
So I think if that's available to you, that should be the one that would be the best option for you.
Okay, so other things here, yes, for what based on the evidence, ivermectin could not be recommended at this point. How about your institution's experience with hemoperfusion? When do you recommend hemoperfusion to be done?
So we don't do hemoperfusion at our institution for ARDS, for COVID. We tend to, the way that we tend to go if a patient is heading in that direction, that we have ECMO available for us, and we would place the patient on ECMO and basically support their lung through that. I have not seen us pull for COVID. We have not used hemoperfusion to try to kind of reduce that load, if you will,
because
inflammatory
we
load.
have tried it actually. I think in the Philippines, as long as your biomarkers, it's more dictated by the biomarkers, which are consistently elevated. You cannot adequately dampen them despite that the patient is on steroids and the other drugs. Yes, if it's available, we do recommend at that point some hemoperfusion. Other things here, how about your institution's recommendation? Do you have problems with your surgeon in terms of doing tracheostomies? Do they require, let's say, negative RT-PCR before doing tracheostomy? How about bronchoscopy? Is your institution with a healthcare worker, comfortable in doing a bronchoscopy? At the same time, there's some question here. How about bi-level mask ventilation? Is your institution comfortable in doing it? If yes, do you follow any protocols?
Okay, great questions. Let me take those in sequence. Those are all very good questions.
Yes, tracheostomy first.
Yeah, I'll take the tracheostomy first. So let me just say one thing about, so there's good evidence to show, and we are trying to stick with this, although the evidence comes out and then, typically it takes a while for the institution to change its mind about how to deal with these patients. So good evidence to show that, actually if you have a severe COVID, for instance, you stop shedding virus. Generally, you stop shedding virus after, say, a few weeks. So it's probably, and we're taking that tact more now when we look at when is a safe time to perform a tracheostomy from the setting of the people who are involved around the surgeon and a respiratory therapist and an anesthesiologist, say, who would be involved in that case. The way that when we do those cases, we still tend to do them later rather than earlier for the health of the healthcare workers, so that they're not exposed. I do want to say that good PPE practice works very well. When I was in New York City, it was basically as I said, that hospital was basically one open ICU essentially everywhere for COVID patients. You wore PPE throughout the hospital pretty much, except for some designated areas where you could take it off and rest. And no one that was there got COVID. Probably the biggest risk of getting COVID was from being out in the community and not in the hospital. Yeah. So as far as tracheostomies, what we do is we basically have one surgeon who is a head and neck surgeon who is the one who does these for us, because he's got the most experience in doing it and has his practice the way that makes the most sense. And then we tend to limit any sort of trainees, so we keep experienced people doing these cases, so that they have the cases are done as quickly as possible in a negative pressure room, if possible, where we can do that. We try to do it in the intensive care unit and not bring these patients to the operating room, to limit just transport of these patients around the hospital. And I think that that's important, if you can, is to limit how much you transport patients with COVID throughout the hospital, if that's a possibility at your center. So yes, we are doing tracheostomies. They're probably done 3 weeks or so to a month after somebody has had COVID. We're not doing it early at all, but the data would show that these patients, even we stop sending COVID tests on them, because they'll still come back COVID positive, but they're not actively shedding virus. And that's what we've been seeing. And that's been a moving target for us, because the data keeps. So same for bronchoscopy. When we do bronchoscopies, we try to limit the bronchoscopy on our patients that have COVID. We still do them, especially on patients if they're having so much secretions, and some of these patients do, to try to keep their lungs clear. But we tend to not do it routinely, only if we have to. So inline suctioning, where we don't break the circuit on these patients, is the best method of keeping the airways clean. But if we do bronchoscopy, again, we're going to keep that patient in in this negative pressure room. Everyone is in full PPE, and we limit the people that are in that room to just absolutely who needs to be there. Usually probably the bronchoscopist and a respiratory therapist, and that's it. Keep the ICU nurse out of that area, because we don't want to expose anyone that we don't have to.
How about non-invasive ventilation, BiPAP mask?
Yes. So I think that's an interesting area. And there's conflicting data on it. Some centers have used it very effectively. I think it works quite well. I think the risk to it has been the possible aerosolization of COVID, but it can keep some people from being placed on mechanical ventilation. I think the things to remember with non-invasive are, so if you have the ability to put somebody in a very isolated or negative pressure isolation type room, in a lot of our negative pressure rooms we've used kind of more, we don't have that, nobody has that many negative pressure rooms. So if we've done stuff where we have basically just these kind of air ventilators that kind of just push air out of the room, that kind of a makeshift area that works as a negative pressure area. And I think those work quite well. The thing to remember about non-invasive ventilation is they're very labor intensive. So when you have a patient on that for a long period of time, while you save them from being intubated, you do require quite a bit of workload from the staff that are taking care of. The respiratory therapist is probably in there more often, adjusting things on these patients. And then other care such as feeding and other things are harder to do on a patient who's on non-invasive. If they can come on and off it, if they only need it for certain periods of time, then I think it makes very good sense to use it. If they're using it almost 24 hours a day, I think it's probably safer to just intubate that patient if possible, and then care for them that way, because it's I think there's less care on an safely intubated patient than on a non-invasive ventilation patient.
Okay, so with the occurrence of variants of this COVID-19, we know there's a lot of concern for variants. Number one, do you routinely test for variants in your institution? And number two, are there, let's say, protocols from your institution when to test for variants if you don't do it routinely?
So the way my institution works is when we get a COVID test, they test both the rapid COVID and they're also doing a PCR test on these patients. And when they do the PCR test, they are checking for variants. So it's done.
Automatic.
It's automatic, and they are putting that into a database so that they can see what patients are coming in and what variants are being picked up. So that's part of.
How is it? Are there a lot of variants in your institution right now?
There are. We see the UK variant actually quite a bit, and that has been, I think people are relatively comfortable with that because the vaccinations seem to be pretty good against that variant. There is also a New York variant and there's a California variant. Some of the variants like out of Brazil and stuff we're a little bit more concerned about. We haven't seen that much of that, but that's always a possibility. And then there's the lurking variant that you don't even know that is still out there or is yet to come. And I think that's, all that speaks to, so people are worried about the variants. I think it all speaks to trying to get, the quicker we can overcome this, the less variants we can get. For us, not at my institution, but within the US, we have a lot of issues as far as people not wearing masks or people not getting vaccinated and not trusting the vaccine. And that's a problem. That's a real problem in the United States. That has been a real, social media has been the enemy of attempts.
So what's your, do you use, let's say, cycle threshold values for your RT-PCR swab, especially, in terms of decision-making, when to move these patients in the ICU to a step-down facility, cycle threshold? Do you use it?
We are not using that. I think that's an interesting concept to use, but we basically are moving patients. The way that what we have basically set up is we have a couple different hospitals that are within our healthcare system, and so one of them we have a separate kind of freestanding COVID unit that we tend to put lower acuity COVID patients in. So once they've come out of the main, if they're in the main hospital in their COVID unit there, or we also in our cardiac unit, one of our cardiac ICUs, we have a COVID unit essentially for patients that are on ECMO. So once they come off of that and then they're stable enough, they can go to this other hospital where they're in an intensive care unit, it's a little bit, it's not quite a step down, but it's still, they're still ventilated there, usually trached and ventilated, and then they'll move from that to more of a proper step down as they come out of that. So we've kind of set a separate, smaller hospital that we used to have, that we were getting ready to get rid of because it's not earthquake standard, but it's a perfect place for these COVID patients at this point.
Do you use other agents like favipiravir for your patients, especially those, let's say, that you just see at the outpatient?
So I have not seen that used in my institution. It might be with some of our outpatients, and I don't have, where I work within the intensive care unit, I am not seeing that being used for us at all.
Okay. What's your opinion as far as reinfection is concerned? Does it actually happen? A COVID-19 patient recovering and then comes back to you with all the symptoms, you test them, it's going to be positive reinfection. It's a real entity.
It is. I think it probably is a real entity. The problem has been that these patients are going to remain. If you test them with PCR, you're going to see the COVID virus in there for a long period, even if they're not infectious. So I think that does make it a little bit more challenging. According to the Center for Disease Control in the U.S., we have had some there are some evidence of patients that have had reinfections, and they try to get that word out so that people that feel like that, mostly from a public health standpoint for us, so that people, if I've been infected with COVID and I go home, I recover from it, yes, I should continue to wear masks, and yes, I should continue to be careful. It's not a guarantee that I can't get COVID again or spread it. So I do believe it is a real entity. It's probably quite rare, but I think it's an important thing to get out to the public, because we don't want them to think that they're now somehow fully immune. And the same with the vaccine, that people who have had the vaccine, I've been vaccinated, and I've been lucky to be vaccinated. We still wear the same PPE and masks everywhere we go. I think that's a really important from a public health standpoint to get out to our patients and our communities that these are real.
For instances of reinfection, Dr. Landy, these patients will still get, the same concoction that you've mentioned, their anti-COVID regimen will be the same?
Yes. Now, I have not personally seen patients that have come back to our hospital that we think are true reinfections. And so we haven't, so I personally have not had this patient, or the opportunity to take care of somebody like that, where we've kind of restarted at ground zero and gone through. But I think that it would make most sense to, if you do believe that this is a true reinfection, to treat them the same way again as you did, so with everything again.
Okay, so a lot of comments here that they are congratulating you because you are quite patient enough, despite the ungodly hours, to answer all our queries and concerns. Much appreciated, Dr. Campbell, and we really thank you for spending this early morning hours with us.
Oh, thank you. It's been my pleasure. My pleasure.
Okay, so I don't think we have any more questions. That's why I like the town hall type. So everybody's awake, and I hope our main speaker, of course, Dr. Campbell, as what you have seen, he's very much awake in terms of answering all our questions and concerns. And with that, Dr. Campbell, any parting words from your end?
Yes, I do want to I want to congratulate everyone who has worked on this project. I think the Learn COVID, the whole project around Learn COVID has been just a phenomenal success. I'm proud to be part of that. It's been really enjoyable for me to partner with you all in this, and I hope that you can learn from the mistakes that we have made in the United States and we continue to make in the United States. It's unfortunate. We're starting we're at a point now, and I'll just kind of get back on the public health thing, and then I'll stop. But we're in a point now where, you know, people are getting vaccinated, and things are starting to open back up again. And there's this big push to open everything back up, and I understand it, but it's been, you know, I think we're probably due for another surge here in a few weeks because of that. And it's just, you know, this is a long, as you said earlier, this is a long fight, and we just have to stay in this fight for a long time, and it's not going to be easy. And everybody's tired, but you know, I can't say enough for how much people have been working, and I know you all on the front lines have been working super hard, and it's, you know, it's,
yeah. Since you mentioned the vaccination, there's a question here. How about, let's say, those who gets vaccinated? Do you anticipate that this is going to be a yearly thing, even if you got the 2 doses already?
Yes, we've been talking about that, and will this become like a influenza vaccine type thing? I think it might. You know, it's because we don't really know how long. We know that we feel pretty confident that you get 6 months of good immunity from it. Again, you know, we don't know how long the immunity for this will last in the long. There's just everything is so new, and I think counseling patients, one of the things that I've tried to tell them too when I've talked to my patients is, you know, there's so much, people get turned off to these therapeutics and everything because, you know, things come and then they go, and then they come and they go. But this is how science works, and this is how medicine has worked forever. And I think it's, for the most part, people haven't seen this in their daily lives. And so they don't understand it. And now making your patients understand that this is how we learn, and that, you know, when new things come along, we try new things, and some will work and some won't, and that's just where we are. But I do think it's probably going to be potentially could be a yearly vaccine, unless we see that people's immunity stay up for a long time. Once we get a herd immunity, I think then things will be better. There are more coronaviruses out there that, you know, probably another pandemic around the corner at some point. And we just, you know, hopefully we'll all learn from this one and be better prepared for the next one.
Yeah, hope to visit your state once we are allowed to travel. Thank you very much, Dr. Campbell, and definitely from all the participants here, we really appreciated all your inputs, all your comments. You're quite candid in terms of the hits and misses that you have. Definitely, this will go a long way as we, you know, ride the tide of our surge right now. So thank you, and hope you can get some shut eye as well.
Thank you so much. I hope to eventually travel and get to meet you as well too. That would be wonderful. So have a good day.
Thank you.
And thank you so much.
Okay, so with that, we would like to close right now this webinar. Again, for everyone's information, go to opencriticalcare.org. It's a good archive for a lot of COVID-related material. For the Learn COVID modules, it's going to be lodged, as what Dr. Suleiman mentioned, in the DOH Academy. So you can also visit DOH Academy. There are free CPD modules there with free CPD units with their corresponding CPD units. So it's worth visiting. Please don't forget to evaluate this webinar by accessing the one that is flashed right now. So the evaluation form bit.ly/COVID-19 web-eval. So for everyone, we would like to possibly improve on these sessions, of course, as we move on. So definitely it was really a good session with one of the frontliners from the US, Dr. Campbell. And again, we thank DOH, USAID, FHI 360 through the EPIC project. And of course, thank you very much to the technical support done by our FHI 360 counterparts, especially by Mr. Gibo Mina. We really appreciate that. So I think the more important lessons here is be ready to see the lesson, acknowledge the lessons, and possibly act on the lessons. So let us maintain our humility and to accept, of course, our limitation. Please don't forget to rest as well, since the surge is still ongoing. And definitely, itong mga instances na to, kapit lang. So with that, good evening to everyone. Mm-hmm.